Okay, so good morning, everybody. I've actually been given the symbol of patriarchy, which is I have the gavel, so it'd be very difficult for me to avoid hitting this. I shall try not to. I shall hand that over so I don't do that today. My name is Anne Keeling. I am a senior fellow with Women in Global Health. Just to let you know, we would like to take photos of this event to share on social media. If you have a problem with that, will you please let us know? Otherwise, I think it's very important that we get the messages from this event out. Please turn your phones off. We're going to change the order slightly. The minister from Niger is delayed, so we're going to change the order slightly, and when she joins us, she can give us her presentation. So I'd like to kick off by saying that the subject of this discussion today are the women who are the 70% of the world's health workers, and they deliver care to around 5 billion people. Every one of us depends on those women for our health and our lives, but the majority of female health workers are concentrated into lower status, low paid and often unpaid roles. Even within the same healthcare occupation, women earn 89 cents for every dollar that a man earns. We need to fill 18 million health and social care jobs, particularly in low-income countries, to achieve universal health coverage by the deadline of 2030. And to achieve this, we have to work across sectors, across health, education, labour, finance and gender. And this was the driver for the creation of the multi-partner programme Working for Health, which was launched in 2017 by the World Health Organization, the International Labour Organization, and the Organization for Economic Cooperation and Development to support countries to expand and transform the health and social workforce to achieve the SDGs. And the Working for Health programme drives investments in skilled, trained and empowered health and social care workers. And particularly, the focus is on employment and decent work, and education and gender equality. And we will talk today about decent work for female health workers. I don't want to take too much of your time because my colleague is going to speak much more about this, but just to let you know that the Working for Health programme is being implemented through a 5-year ILO, OECD, WHO action plan on health, employment and inclusive growth, 2017 and 2021. And the work that we're doing here under the Gender Equity Hub, which is co-hosted by the WHO and Women in Global Health, is really about transforming the health workforce, particularly for gender. The programme enables countries to make critical investments and gains in job creation, decent work, gender equity, women's empowerment and inclusive economic growth. Our point today is that business as usual isn't going to be enough. Continuing with the same gender inequities in the health workforce will not give us the transformation that we need. It will not give us the solid platform that we need to build better global health. We need gender transformative policies. So today we launched 2 reports that shed light on the root causes of the pervasive gender inequality in the health sector. The first report is Global Health, delivered by women, led by men. And that's a gender and equity analysis of the global health and social workforce. And our colleagues will be discussing that today and delivering that today. That will be critical for achieving universal health coverage. The second report is Gender Equity in the Health Workforce, an analysis of 104 countries using labour force survey data to estimate occupational segregation and the gender pay gap in the health sector. Both these reports call for gender transformative approaches that go beyond just promoting gender equality and gender parity. they assess and address the root causes of gender inequality and how we can build implementation capacity to overcome gender biases and inequities in the education and health labour market. And this is all about transforming health and care social work into jobs and decent work that work for women. Thank you. So I would like to hand over to my colleague, Rupa Dutt, who is the Executive Director of Women in Global Health, to present for us the first report, Global Health, delivered by women, led by men. Thank you.
Great. Thank you, Anne, for particularly providing this, great opening, which really lays the foundation of why this report is such an essential report for us. So it is with great excitement to officially launch, and it should be live online for those that are tuning in, the launch of Delivered by Women, Led by Men. For those of you in the room that would like a copy, there are some copies available here in the front and also available digitally. There is the link on this PowerPoint screen that you can see above. Particularly, we know that women are drivers of health. Women make up 70% of the 200 million workers who contribute to the health and social sector. They deliver care to about 500 billion worldwide. They contribute 3 trillion annually, half in the form of unpaid care work or basically unpaid work altogether. That's 50% of their contributions in the health and social sector. And with a predicted shortfall of almost 18 million health workers by 2030, investing in the health and social workforce is investing in women's economic participation and empowerment. And that's why this report is a key aspect and very timely. As mentioned earlier, this report has been produced by WHO and Women in Global Health as part of the Gender Equity Hub, which is housed in the Global Health Workforce Network. This hub is co-chaired by WHO and Women in Global Health, and really the purpose is to accelerate large-scale gender transformative progress to address inequities, bias in health, and the social workforce. Particularly when we look at the report, the key objectives of this report were in addition to identifying what the latest available data, to examine case studies, policies, tools, and strategies and their impact in addressing gender inequities, particularly in the health workforce, to map programs, initiatives, stakeholders, campaigns, and intersectoral work relevant to addressing gender inequities and bias in the health workforce, as well as to synthesize lessons learned from the evidence, programs, and initiatives and campaigns, with a key purpose really being to drive policy action and implementation. The methodology which was used was coupled with a global call for case studies, particularly for peer-reviewed articles, gray literature, policy briefs, program interventions that were done after the year of 2000. There was an open virtual call. Additionally, a comprehensive, robust literature review was conducted, and Gender Equity Hub members also participated. Articles that provided evidence from 3 other sectors were also added: technology, corporate, and finance, and a draft report was made available for consultation. The key limitations we noticed in doing this particular review is that there was a limitation in the data, particularly from an intersectionality perspective, so not really being able to find research and publications that looked at things beyond gender, so particularly race, geographical distribution, socioeconomic status, disability. All these components were not part of current research. The geographical focus was very geared toward the global north and English-speaking countries. Occupational focus was particularly focused on women in medicine, physicians specifically, not the entire spectrum of the health workforce. Sex and gender disaggregated data was also limited. Most of the studies that were done were framed from the perspective of looking at women in the workforce and not necessarily applying a gender and equity lens. So in highlighting, as you can find in the report, there are several key findings, but particularly the 4 areas that we focused on are occupational segregation, leadership, decent work, which includes looking at decent work free from all forms of discrimination, sexual harassment, and bias, and then looking at the gender pay gap. The findings in the research gap, the major gaps in data and research were from low and middle income countries on gender and equity dimensions in the health workforce. Gaps also were around implementation research on impact of policy change or gender transformative approaches in different cultural settings. So in other words, very limited studies out there that really show us what works and what works in context-specific settings, particularly from a policy implementation perspective. Other gaps that we also noticed was particularly topics such as sexual harassment and gender pay gap data was very limited, and it was difficult to make it comparable across countries. And then finally, with the other key finding is that health workforce research is limited in its methods. Very few studies on health workforce adopt an intersectionality lens, as mentioned earlier, or used mixed study approaches. So particularly adding qualitative data, including life histories, and just having a more rich data pool on the health workforce was also limited. Specifically diving into the findings in the occupational segregation, there are two graphs here on the screen, and what this really is talking about is both horizontal and vertical occupational segregation by gender. So we know that women are concentrated in particular fields of work, and if you look at the very top graph on the PowerPoint, on the top left, what you will notice there is that women are particularly concentrated in the roles of being nurses. And then if you look at the graph right below, it's actually showing particularly the percentage of nurses who are men, and that has not really gone beyond 12% over the last 40 years. We also know that occupational segregation impacts service delivery and the health system by limiting full participation of all genders, and it really fosters greater gender inequities. Both horizontal and vertical occupational segregation by gender are found globally in the health sector, but vary depending on the context and the history of the country. Occupational segregation has its roots in two cultural ideologies: gender essentialism and male primacy. We also know that occupational segregation is driven by gender norms that define caring as female work and portray men as more suited to technical specialisms in medicine. We also know that gender discrimination is a primary reason for women not entering high-earning medical specialties, while gender stereotypes deter men from joining female-majority professions such as nursing. The horizontal and the vertical dimensions of occupational segregation combine and cluster women into lower paid jobs, lower status work, with a lifelong impact on their earnings and economic security in the old age. Female-dominated professions, including caregiving and nursing, tend to be given lower social value by gendered social norms. Next, we looked into particularly the area of decent work. As we know, gender discrimination and gender inequality within organizations are linked to low morale, low self-esteem, and low productivity for the workers, and it affects mental and physical health. We know that in the health sector, this has an impact on the delivery of health and the quality of healthcare that is provided. We also know when we look at the global landscape of laws, the graph on the left shows that 59 countries do not have laws prohibiting sexual harassment in the workplace. Moreover, when we looked into data around workplace sexual harassment, surveys showed upwards up to 50% prevalence of sexual harassment, particularly a survey which looked at which had about 1,000 respondents from National Institutes of Health Academic Career Development Awards. 30% of women reported having faced sexual harassment in comparison to men having 4%. Women are more likely to face sexual harassment in the workplace than men. We know this as a given. While the Me Too movement has encouraged more open discussions of sexual harassment in some countries, it remains a serious and widespread abuse, causing loss of morale, stress, and ill health for survivors. Female health workers, particularly in conflicts or emergencies or working in remote areas, can face violence in the course of their work. Within a number of female health workers are severely injured and killed every year. Next, we looked into the gender pay gap. So as a point of clarification, gender pay gap is different from equal pay. So the graph there demonstrates, particularly the image there, that equal pay is about, means that men and women performing the same role must receive the same pay. Gender pay gap actually looks at the difference between average earnings between men and women over time. Looking particularly into the gender pay gap, one study found that women physicians earned 11% less if they were married, 14% less if they had one child, and 22% if they had more than one child. So I'm going to let that settle in for a moment, because it just shows you how these institutions have been designed for men and not for women to thrive. Some additional highlights from the gender pay gap. The unadjusted pay gaps in the health and social sector are estimated at 26% in high-income countries and 29% in upper middle-income countries. We'll be hearing about the latest data on this shortly. Occupational segregation by gender, with women tending to be clustered in a lower status, lower paid sectors, and specialization results in associated gender pay gap in favor of men. Equal pay for equal work legislation and strong collective bargaining is still absent in many countries, and it is essential for addressing the gender pay gap in the sector. The gender pay gap also result in lower lifetime income for women, which results in increased poverty, particularly for women in older age. The next priority we looked at is particularly in leadership. So what we notice when we look at leadership in health, these two images here, the one on the left shows that if you look at global health organizations, and this is data from a report called Global Health 50/50 that was released in 2018, we notice that executive directors of organizations called Global Health, only 31% of these organizations have women in lead executive director positions. When we look at board chairs, governance of these organizations, women only hold 20% of those seats. And if you look at the right, where what we call the Global Health Leadership Pyramid, really looking at the people that are providing the social protections, providing health care, and are part of the social workforce, long-term care, nearly 90% are women. And if you go up on that pyramid, you'll notice 70% of the health and social workforce are women. And as you look up to the top levels of it, particularly decision-making, ministers of health, and decision-making representation in global health organizations, the percentages are around 25 to 31%. And finally, particularly at the private sector, if you look at Fortune 500 companies in the healthcare, only 5% of them have women as head in the CEO position. So key messages: workplace gender biases, discrimination, and inequities are systemic, and gender disparities are widening. Many organizations expect female health workers to fit into systems designed for male patterns of life and gender roles. Example, no paid maternity leave, no paternity leave. Other key findings, particularly from the leadership aspect of it, is that the persistent absence of female talent from leadership positions is likely to prove a significant barrier to the rapid scaling up and the global health and social care workforce needs to achieve the SDGs. We also know there is evidence that women in leadership positions and health expand the agenda, giving greater priority to rights, such as sexual and reproductive health and rights, and that applies to all genders, but where absent can have the most negative impact on women's health. And our recommendations are: it's time to change the narrative. Women form the base of the pyramid on which global health rests and should be valued as change agents of health, not victims. As part of changing the narrative, it's also critical to record and recognize all the work women do in the health and social care, paid and unpaid, and bring unpaid health and care work into formal labor market. We also are asking for gender transformative policies. They should be adopted in a way that challenge the underlying causes of gender inequities instead of policies that fix women to fix the inequitable systems. We need to fix systems to create decent work for women and close gender pay gaps in leadership and pay, and ensure that they have enabling environments free from all forms of discrimination and harassment, including sexual harassment. And we also would like to encourage the research community particularly to shift the focus of research in global health and social workforce so that we prioritize low and middle income countries. We apply gender and intersectionality lens and include sex and gender disaggregated data, particularly having research that looks at implementation and research that also looks at power relations. And finally, we also ask for greater accountability on the Working for Health Action Plan, particularly having a midterm review to make sure there is progress on deliverables on gender equality and recommend steps to ensure delivery of the action plan commitments by 2021. And I'd like to say a special thanks to everyone that made this possible, especially to the Women in Global Health team. Our lead author, Meher Manzoor, is in the room right there, so I'd like to say thank you to her. Anne Keeling, who is chairing this particular session, and our communications person who's made all this possible. Without listing all the names, special thanks to the World Health Organization team, authors and contributors, colleagues of the Gender Equity Hub, as well as supporters of the Global Health Workforce Network, and their information can be also found in the report itself. On that note, I am delighted to really launch this report and hope that this will be a platform for greater policy action. We must act now. It is imperative. We're not going to achieve universal health coverage, nor are we going to achieve the Sustainable Development Goals if we don't have a fit-for-purpose health workforce, which is majority women, and that we truly apply a gender and equity lens to this work. Thank you.
Thank you, Rupa. And I'd now like to turn to Werner Obermeier, Deputy Executive Director of the WHO Office at the UN, to present Gender Equity in the Health Workforce Analysis of 104 countries. Thank you.
Thank you, Anne. As Rupa has mentioned, there is another report that we are launching today, which is the one we are going to have a quick snapshot of right now. She has mentioned in the previous presentation that there are large gaps highlighted and the need for better data. So WHO has worked with ILO to gather such data on gender equity in an analysis of 104 countries where we have found such labor force survey data. WHO has actually worked with ILO for several years on the issue of the health workforce and supported the work of the Secretary General's high-level panel, the commission that was established 3 years ago on health, employment, and economic growth. So this is an area that's receiving a lot of attention here in New York and globally. So if we look at the findings of the report, Rupa has already mentioned that women represent 70% of those employed in those sectors. So in many ways, it's true that women deliver health, but men are paid for it. And you will see there in the other the bullets which are highlighted that there is a gender gap in pay of 28% on average. I'll speak to that a little bit later, but once you factor in part-time employment, the real gap decreases to 11%, which of course is still way too much. It's important, as Anne has mentioned earlier in her introduction, that we look specifically at gender transformation policies so that we can eliminate discrimination in terms of earnings, but also to remove barriers that women find to access full-time employment and support access to professional development and leadership roles for women. The occupational segregation slide, which is the next one, is something which was touched on by Rupa in her presentation. Interesting there to note that only in Europe you will find that there are more female physicians than male across all the regions that we have analyzed. There is, of course, a change in recruitment, particularly among male nurses, but this is a gradual change, and so we find that globally women make up the large majority of nurses still, which, as you know, are also on the lower paying scale of employment. There is a silver lining, which you see in that data. There are some improvements in occupational segregation. Women's representation has increased over time, particularly in the higher wage care occupations, which are the physicians and your dentists and pharmacists. Also, a very positive signal that we have picked up is that in the age group under 40, the majority of new health workers entering the market in higher paid wage occupations are in fact women. So that is a very, very good signal for us. The next slide shows that women healthcare workers are more likely to be employed in part-time positions, which obviously have less job security. And a particular interest here is what Rupa also said, that up to 50% of the economic value contributed to women in healthcare are unpaid. So the contribution is massive and unreported. The pay gap, which is the next slide, which I mentioned earlier, gives you here with this graph a little bit more information. So if we factor in the working hours and then the other conditions, the gradual decrease from 28% ends up being 11%. Obviously, this is also due to women occupying less senior positions and gender discrimination, to be frank. We also estimate that the 11% will decrease to 7% over the next 20 years. So there is some improvement, although very, very slow and not nearly good enough. The final slide are some policy considerations, and I want to preface this by saying that when the Commission, which the Secretary General established in 2017, brought out their findings, there was a very alarming trend identified. Rupa has said that there is currently a shortage of 18 million health workers, but in the 2050, that shortage is projected to be 40 million. And we will never reach the health goals and targets included in the Sustainable Development Agenda if we don't focus on this and invest in women's employment in the health and social sectors. So in terms of the policy considerations, in the gender pay gap, we will call on countries to implement the ILO's Convention number 100, which focuses on labor rights against sexual discrimination. And by implementing that convention, we will also ensure equal payment for men and women for work of equal value. We should capitalize on the momentum of increasing female participation in higher paid healthcare roles. We should also ensure secure employment and decent work by removing barriers to access, which I addressed earlier on. And then, of course, the move towards transformative policies. This is something that all of us should work together to create some pressure on governments to implement. Thank you. I'll leave it there.
Thank you, Werner. And I'd now like to turn to some personal reflections from the field from Amaz Louis-Pierre, who works for Zanmi La Santé in Haiti, which is affiliated with Partners of Health. Amaz is a trained social worker, and she has worked particularly with orphans, HIV/AIDS prevention, and now works on gender-based violence. Thank you.
Merci de m'avoir présenté.
Thank you for presenting me. I am not in the situation in the health in my country is not any different from what's been described in the reports. If I consider where I work in Partners in Health, which is evolving in 11 countries, there's only Haiti, which has a woman in responsible position. and otherwise the leading positions is taken by men. For example, a woman leads the organization, and they think they're thinking now about leading and not being led. And thanks to Zanmi Partners in Health, the second thing is that all the posts of the leadership posts are in the second level are done by men, and in the third level we're finding women now, social assistants. But the problem is that if you go down to this third level, where we're coordinators. Is there? Do we all have the same advantages? No. There's always a gap in power. Is it because I'm a woman that I can't coordinate when I coordinate a project? Shouldn't I have the same pay as a man? It's not going to be the same. If you have the same post, you should have the same social advantages and the same pay. Now, in the structure, the general structure, that's the general structure. Now, if you also go into the hospitals in the 12 communes where we have 12 hospitals, but all the hospital directors are men. There are women doctors and also who are coordinators, but the assistant doctors, but all the leading positions are occupied by men. We women, what is our role? We're auxiliaries. We're nurses. But we're not We're not directors. Why? Because we're women. So on this, so there's 26 social workers, for example, in this example. This is a struggle, so that social workers have the same salary. And you can't. You should have a decent wage if you're leading a program. We're professionals. We should have a decent wage. And sometimes you can be a social worker and you can't have the same salary. And this is a gap that has to be eliminated. And what would I suggest from according to my experience? The partners in the institutions who are seeking financing for their projects, I would ask the financiers to look at the to insist that we have equal pay. And for example, if there are decision making roles in the project, we should insist that to be equal men and women, and not just men doctors, because otherwise we'll never get there. And in particular, we all this discrimination, which we have to have what I would call positive discrimination toward women. For example, in Haiti, because it's a poor country, and the women don't suffer then in the health roles, and then in the national level. Why should we must arrive at our objectives so that there's equality, decent work for women, and training for women, and if they're already professionals, to create programs to accompany them for their pay, and also it's a structural problem. We have to work to create programs that will address this problem. We must have the possibility for young girls to evolve, and if in the case of girls, would tell them, you're a girl, so you must learn to be a secretary. You should go in certain roles which are reserved for women. You shouldn't go to medical school. You shouldn't go to law school to be a lawyer. So we have to work with the parents also, so that the girls have the same chance as the boys. They can so that when the girls don't think I must be a secretary because I'm a girl, but you can also be a doctor. You can be a lawyer like the boys, and they should have the same chances. And the other thing is, you should also have. We should have a partnership with the Minister of Women's Work, women's condition. And why should we do this? Because it's necessary to exert the pressure that then and so that you have situations where there's no structure. For example, you have with NGOs that are financed by the Minister of Public Finances, and why would you not finance also institutions to reinforce the capacity of the women's condition? We can act and against these barriers that prevent us from really realizing our objectives. And so that's my recommendation. Thank you very much, And I can't remain. I'm afraid I have to participate in another meeting, but I thank you very much. Thank you very much.
We're now going to change format, and we're going to go into a panel discussion. We have 5 panelists for you coming from quite different perspectives. On my right, we have Sarah Walji, who is on the board of Nursing Now. We have Madame Mariama Chipko, I'm sorry if I'm pronouncing your name wrongly, from the Ministry of Education in Niger. From WHO, we have Michelle McIsaac, who's been working on the gender pay gap in particular. From ILO, we have Mr. Vinicus Pinheiro. And from the government of France, we have Anne Guergan. I'm sure I've got your name totally wrong, I'm sorry about that, who is the Deputy Permanent Representative for France to the UN here in New York. So I would like to ask you, coming from your very different perspectives, I'd like to ask you all the same question. And I think I'd like to go around the room this way. What would be your key policy recommendations to advance gender equity in the health and social workforce? Where do we need investments to realise the full potential of the health and social sector, and particularly women? So that's what would be your key recommendations to advance gender equity. Michelle.
So for me, I think that it's a little bit about going beyond the visible. So we've done a really good overview here of what we know in terms of gender gaps in the healthcare sector. But I think it's also about what we don't know in the gender gaps in the health sector. So I think that, of course, the 2 reports give an excellent overview of what is known. For instance, that gender segregation is the main driver of the gender pay gap in the health and social sector. So it's clear, it's obvious that policies need to address gender segregation. But we also need to go beyond this. We need to consider the more invisible drivers of this inequality, be it unreported sexual harassment, burnout, high levels of informal care, unpaid care, or as our colleague from Haiti highlighted, preferences at the home for what kind of work you can do if you're a woman. So we need to ensure that we advance the social protection system to cover these areas. So ensure that gender transformative policies that we enact are not just to advance economic development and inclusive growth, but also social development and human rights, including the right to work and to education. So my key policy recommendation would be to take a 2-pronged approach when we're looking at policies. Of course, we need to address the visible drivers of inequality. Of course, we need to go down this route, but we also need to, while doing so, keep sight on the more invisible drivers of inequality.
Thank you. Mariama.
Au Niger, cette inéquité.
In Niger, we have, beyond the question of scholarization, school, we have 45% of those in school are only women, and only 3% of women finish in their education in Niger, and we have an enormous number who quit school. so in order to have sexual equality, we must imperatively have we must have girls who go to school, and also create the conditions for the reinsertion in the school, but of those who resigned from school, who left school, and we must create the conditions for the reinforcement for the technical education for girls, and encourage young girls to go into scientific fields, because in general, we think that the scientific fields are only for men, and that the girls should only be interested in literature. But you also have to underline that in Nigeria, our country has taken in hand the UN recommendations concerning employment and health. And we have national investments in the health sector, and also we have a projected pipeline for the health education, and in order to encourage the economic development. And this is the plan was adopted at the presidential level, and so we have to create 11,000 jobs in the health sector, and create trainees that they can, because otherwise they'll be left behind and will not be and will not stay in school. And of course, we have to empower the mayors, the mothers of these girls, to encourage them to stay at school, and not just simply do domestic work. The most important is the mobilization of resources in order to achieve these aims, and in the rural pipeline. Thank you very much.
Merci. Anne.
Oui, merci beaucoup.
Thank you very much. Yes, France is very happy to be able to co-host this event with Niger, WHO, and Women in Global Health, and ILO. And I'm particularly happy and honored to be among you, because I actually come from a family of doctors, and I originally thought I was going to be following that route rather than being a politician. And people who work in the sector come across these obstacles that have been mentioned. And my mother never took the higher level specialized doctor's exam, because she was told, "Madam, you would be replacing a man if you pass that." Minister Buzyn, who's a woman, is very committed in our government and working for this cause nationwide, that is to promote gender equity. This is a major priority that has been identified for the 5-year term of the president, and also for the French presidency of the G7 this year. We'll have a G7 health focus that will be looking particularly at this question of gender inequality in terms of health. I would like to give you a few figures concerning France to show the progress achieved in Western countries. Has much to accomplish still. So 45% of leadership positions are held by women, and 80% of direct health providers are women, and only 20% are leaders of women or leaders of institutions, and only 10% of women head the major prestigious hospitals in France, the university hospitals. And in terms of inequalities in salaries, that's also major. For full-time staff, women are paid much less than men on average, and that's regardless of the kind of institution. So what can we do? to even things out? Well, there are many causes. There are obvious causes, and then there's hidden causes. There's the lack of equal sharing of the domestic tasks, and that weighs on women doctors. There's also a type of discrimination perpetrated by employers who say that women are less flexible or less available. So, in short, there's two main ideas. We need to have measures that give incentives to institutions to recruit women at a high level. And secondly, we need to make sure that women take full part in the preparation and adoption of public health policy. Thank you.
It's a pleasure to be here and a pleasure to be in a room filled with such energy and such dynamics. Honored to be involved. So policy recommendations, and it's just really building upon the themes that have already been mentioned by my colleagues on this panel. It's creation of safe spaces that welcome the invisible to bring conversation points to the table. We want women to be more engaged and more involved, so creating the welcoming environments which facilitate those opportunities to occur. A lot of the times we don't hear from the underlying stories. We don't hear from the invisible. Why? Because we aren't given that voice in that aspect of work. We aren't given that voice within that realm. So how can we have policies that integrate that open opportunity and that facilitation within that context that allow for women to bring these issues to the table and really articulate it from their perspectives, their culture, their experiences, so that it creates that context that allows for growth within the applications of the countries or organizations in which they're working in. So opportunity creation, I know this has been really, really vital, especially for youth within our generation, millennials, the Gen Z, and I think I was having conversations with colleagues earlier about this. Youth, especially female youth, have noticed that there is quite a shift towards engaging and having us more involved and at the table, and I think opportunity advocacy has become quite vital within that regard. So applications within the gender dynamics are quite applicable to this realm as well. So integrating women into that opportunity space, having those doors open. Sometimes we got to bring the chairs, but it would be great if we actually had a name at the table so that that creation of that opportunity was already provided for us. The policies which facilitate that, again, within the context of the organization or the culture that they're being applied to. In terms of investment, I come from a campaign board in which a huge amount has been put into advocacy for nursing at the leadership frontier, nursing on the global level, bringing out nurses into the forefront. Nursing now has become a movement globally, and we've seen the impact of it, and that was done through investing within a campaign-based setting that was focused on advocacy and awareness. We are seeing investment within reports, evidence suggesting that there is vitality in having women at the leadership levels. There is vitality in having equal spaces for women. There is vitality within having women that are paid appropriately and appropriately employed. And we're seeing an emergence in evidence, and with the evidence to support the policy, there is outcomes which can be expressed and applicable in a number of different settings. So investment within further research and evidence-informed literature that supports an actual active outcome would be great. And then the campaign aspect of things, as well as creation of opportunities. I know that a number of organizations always advocate for funding, and it's really off of the premise that they do need the funding to go into creation of these opportunities, because without that, we don't have that kind of ability to bring that or bring individuals within these spaces. So those are kind of the points from which I come and my background that I bring to the table. And again, it's off of experiences as well as conversations that I've been having, as well as consultations that we've been having. It's having these conversations that don't necessarily occur in the visible, but rather in the background, and bringing them to the forefront and facilitating that opportunity to occur. Thank you.
Thank you. Vinicius.
Thank you so much, Madam Moderator. Good morning, everyone. The ILO is, of course, very pleased to join this team organizing this event, and we are also super pleased to be part of this joint effort together with the WHO and OECD to implement the conclusions of the Health, Employment and Growth high-level task force. Basically, we see the health sector as part of the solution, so that's why we are so pleased. As you know, we are moving towards difficult, let's say, times for employment because of the future of work, changing technologies, the huge impact of accelerated technologies in the labor markets, some automation in some jobs that perhaps will lead to unemployment, but also, on the other hand, the possibility of expansion in other sectors. And the good news is that the health sector is actually very promising in terms of generating jobs in the future, contrary to other sectors. So we estimate that by 2030, around 139 million jobs could be created in the health sector, because this is one of the sectors that the level of automation will not be very high, because we need something there that is a human touch that is not replaceable by any machine, by any robot. So that's why there's a lot of important perspectives in the health sector, and I'm sure there'll be a lot of men looking for jobs actually in this sector as well, because there'll be displacement in other male-dominated sectors. On the other hand, the sectors on science, technology, engineering that are male-dominated will also increase, and we hope to have more women join this dynamism as well. But the problem, as was highlighted by the previous speakers, and I don't need to repeat that, and actually I'm so pleased that the both reports address quite well things that we have been saying for a long time, and in particular having my colleague from WHO calling from ratification of Convention 100 is also an important step in terms of policy coherence in the UN system. So we are very pleased for that. But in terms of policy responses, let me just quickly and telegraphically mention 5 things. First, care. I think the distribution of unpaid care work is something that's holding women back in terms of participation in labor markets and getting better jobs. And then we have what we call the 5R framework for care work that was published last year, that says we need to recognize, reduce, and redistribute unpaid care through measuring care work during decision-making processes, investing in care sector, enacting gender-responsive family leave policies, ensuring gender-responsive social protection systems. Second, we need to reward more and provide decent work for care workers through regulating and ensuring that decent work conditions for care workers, including migrant workers. Now, we shouldn't lose sight of this important part of the labor force in the care economy in particular that are composed by migrant workers. And finally, the fifth R is representation. As highly pointed out by my colleagues, we need to enhance social dialogue and collective bargaining for care workers, because that's the way you get better salaries, as my colleague from Haiti just mentioned, the salaire décent. So the second point is skills. I think because it's sometimes we are talking about activities and tasks that have been performed without pay, there is a tend to undervalue and overlook the national the skills that are required for care work, which could be quite important. So there is a need to invest on that on a lifelong perspective. Enhancing social protection coverage, which is one of the themes of this CSW, in particular through the gender lens. And just to throw some numbers, maternity protection is 45% coverage for time. Parental protection is even lower. And also, only 73% of the world population, they don't have access to comprehensive security schemes. The issue of work-life balance is my fourth point, and that has to do with better capacity to establish boundaries and to connect and have a more balanced connection between the work and life. And then there's this concept of time sovereignty that is quite important, more flexibility in the way that we arrange the time. And finally, and I stop here, Madam Moderator, violence harassment, as my colleague from the WHO also mentioned. And we are very pleased that this year there is a discussion at the International Labour Conference about a new standard on violence and harassment at work, gender-based violence and harassment at work. That will be a major breakthrough in terms of providing references, international reference for legislation, for national legislation, and measures to combat violence and harassment at work. Thank you so much, Madam Moderator.
Thank you very much. I'd just like to, we just received a message from the Minister from Niger that she is unwell and has been unable to join us today. So I'm sorry we didn't get you that message earlier. We've just got 10 minutes left for the panel, so I'd like to throw one question out to the panel and ask you for one recommendation, your top recommendation, so we know that sexual harassment against female health workers is just about endemic. And it comes from male colleagues, it comes amazingly for me from male patients, and it comes from the community. We're sitting here today at CSW, women talking mainly to women. How can we engage men in the fight against sexual harassment against female health workers? So I'm going to start with you, Wena. Can you just give me one top recommendation for engaging men on this issue?
You know, I think that this requires really a mindset, and the work that you do at meetings such as this commission is a crucial way of bringing that change of perspective to be. Often people look at the difficulties in negotiating an outcome at meetings such as this, and that is only one part of the work of the Commission. But meetings such as the ones we are having this morning, we'll have tomorrow morning, and all the events and work and networking you do on the sidelines of such meetings really helps to change the perspective and bring the change about we all want to see.
Thank you. Anne.
Comme vous le savez peut-être, la France...
As you probably know, France is really engaged with Kenya and also Netherlands with Israel to push back and eliminate harassment in the workplace. And we're particularly mobilized at the UN. We started a group of friends to eliminate the harassment in the workplace, which includes the diplomats, of course, but also has an objective to really is truly collective. And this is also translated into the General Assembly of the UN last autumn. The resolution that comes up every 2 years on the equality of women, this is the first time that would raise the elimination of harassment, sexual harassment. And it's a kind of conversation which is becoming wider, and we want UN to include the health sector, like all sectors.
I just want to add a quick point here and do a little bit of promotion for WHO. Anne has reminded me about all the work that member states do here, but in WHO we have actually adopted now a guideline for staff where all staff must complete training on sexual harassment, and this is mandatory. So if staff do not comply with the training and complete it successfully, their increases in salary or promotion are all put on ice.
That sounds good. Let's evaluate it and see how that works. Mariama, one top point.
I
think it's really important to sensitize the men who have responsibility in the in the health sector so that they bring the struggle against discrimination, and you have to include the trade union organizations who have a very fundamental role also, and that will help to bring progress.
About mainstreaming or multi-sectoral work. We bring in together often ministries of labor and economics and health and education, and we often don't see the ministries of gender included in this multi-sectoral dialogue. So I think the more we bring this as an entity and bring those perspectives in, the more that we're going to have positive, uptake of the messages.
Thank you. Vinikis.
Thank you. I mean, for me, and I think I addressed that in my previous intervention, it's clearly there is a need for a clear institutional and legislative framework, because, of course, everybody here will know when you were or when we were harassed or suffered violence, but a clear institutional understanding of what it is. It's still needed. If you look at legislations in many countries, a concept of violence harassment is not quite consistent. Now, for example, is the violence and the harassment in the way to work considered violence at work? We think yes, but many countries don't. And beyond the sexual harassment, there is also the psychological harassment and the physical harassment, which are quite important as well, and sometimes leading one to each other. So what is needed is this clear institutional framework that has to have a very strong message in terms of prevention, and that's precisely what Werner and other colleagues were highlighting: education, prevention, things that impede that this will happen, to protect the victims, and also to punish. So these are the three P's, let's say, of the institutional framework that has to be understood by everybody. Because if I don't understand, we don't have the same understanding what is what, it's difficult to address. Thank you.
Sarah, final point.
Just to kind of summarize and build into everybody's points, it's collective momentum. So having a conversation that's going to go beyond just our small groups, beyond those affected. All of us know of stories. All of us have been impacted in some way, shape, or form, especially as frontline workers. I know in my practice, I've had instances where patients have come and inappropriately spoken with us, inappropriately touched us. We've had fears of violence on our unit. It's having these conversations and bringing them forward to the table and having them in a wider context and having them across sectors and having males and females involved so that we're getting that advocacy on both ends.
Thank you. And I'd like to say thank you very much. That wraps up our panel. Thank you to our panel. I'm just going to hand over now to Rupadat to give us some closing messages. Thank you.
Thank you, everyone, for really being here for this very key discussion, and really hope that this is just the beginning. These reports are meant to be truly a launch pad for greater action that happens at the global level, but really action that we take back into our communities to the national level. So if we really think about, what we have ahead, we have a very ambitious agenda when we look at the Sustainable Development Goals, particularly with the goal for universal coverage. And a key thing to recognize is that we can't have strong global health if it's based on inequality and on women's unpaid work. So a lot of the conversations and reflections from our panelists has been very much about having women's rights, human rights, decent work, workplaces free from all forms of harassment, discrimination, safety. But, it's also very much about, as pulling from the conversation today, about changing the narrative. We need to start to see women as leaders. We need to see them as valuable drivers of change in their communities, drivers of health, and we need to start investing in women. And this means not only investing in them upfront in education and training, but investing in every aspect of their journey in the workforce. But it is also very much about going beyond women and investing in all genders and really having a gender transformative approach to the health workforce. We need to invest in enabling environments, engaging men and all genders as allies. And we'll see the results of this when we see women represented in equal numbers in decision making. And we'll also see these results when global health and overall health for all is achieved. Specifically, gender transformative policies are essential to scaling up and creating stronger health systems for universal health coverage. Women in global health, with many other partners, for leading up to the high-level meeting, which is taking place in the city in September on universal health coverage, is launched a call to action on gender and universal health coverage. We encourage all of you, as civil society, as academics, as individuals, policymakers, representatives from international organizations, especially member states, to make sure that moving forward, everything we do in health and everything we do in other sectors has a gender dimension to it. Additionally, recognizing that this report and the two the paper and the report that was released today is really seen as a stepping stone. The Gender Equity Hub particularly is a great way for you to engage on the gender dimensions of the health workforce, but there's a broader platform in the Global Health Workforce Network. There are many other coalitions and groups to get involved. So really there's a huge value in partnership, and we really hope that you will take the findings of this report, be part of our work as we really talk about policy action and coming up with implementation solutions at the country level and community level, so we truly have stronger health systems and we no longer have a reality where 50% of the health sector, particularly women, are no longer paid. We truly need women to not only deliver health, but also lead it and be paid for it as men are. Thank you.
Thank you. And that ends our session today.